In this last part of the lecture, I want to start some reflections on how one might think about primary health care now for the 21st century. We can't answer all the questions, but the aim is to raise some of the questions and some of the implications it has for how one might move forward in improving access to primary health care. To begin the discussion, we have to recognize the major achievements of the past 25 or 35 years. So we're no longer talking about absolute scarcities, except in the most deprived areas. There's now a global network of health facilities, public and private, large facilities and small. There are large numbers of a wide variety of health workers as a result of 35 years of major increases in training. There are effective mechanisms for distributing drugs. It's hard to go to a place now where drugs don't reach. Very different to the late 1970s. There are many national and global public health programs. And as I said, there are multiple channels of information. And there have been substantial increases in health expenditure by governments and also out of pocket. The point is, the focus now is much less on building the basics of a health system, but in improving the performance of these pluralistic, complex, and not necessarily highly organized health systems which have emerged. This leads us to need to think beyond the building block perspective of a static creation of multiple building blocks. And I just want to go through some of the implications here. With human resources, rather than a focus on meeting targets for more health workers, much more emphasis is now being placed on the roles and responsibilities of different public and private providers. What incentives do they face, and how is this influencing their performance? How do we monitor for the safety of what they're doing? And the effectiveness, how can we be sure that they are more effective in meeting needs? What is the role of government? What is the role of professions? And what is the role of markets in ensuring that people provide a good service at a reasonable cost? In management, there's much more focus on management issues now than in the past. And this is both within organizations. How do you manage organizations to perform well in providing services? What is the relationship between hospitals and primary health care clinics, between the public and private sector, between NGOs and governments? How could those relationships be managed? And how can they be managed to influence performance, particularly in meeting primary health care needs of the less well-off? As opposed to 35 years ago, it's not difficult to find drugs and basic medical equipment almost everywhere. However, it tends to be in disorganized markets. There's public and private and major problems with counterfeits or low quality. How can we bring order to these unorganized markets? How are incentives operating, for example, where doctors are giving bonuses if they sell more of a particular drug? What are the appropriate incentives? And what kind of regulatory partnerships can be established to make sure that there's effective use of both these drugs and equipment? It was plausible in the late 1970s to think of health systems mainly financed as a government service, plus perhaps some support from the international community. But in these pluralistic health systems, we now have multiple sources of finance. We have government, there have been donor agencies, in many countries there are insurance schemes, people are paying quite a lot out of their pocket. And the question then is, how would these work together to finance universal access to primary health care? And how could they work together in a coherent way to do so? There's clearly been a spread of the media and of content producers of knowledge, including commercial advertising agencies, advocacy groups, as well as governments. And there's a real question of less about getting access to knowledge and access to information, but access to reliable and trustworthy information that isn't expressing the interests of particular private actors. So there's an increasing role of knowledge intermediaries, organizations that out of all the complex evidence available can make useful knowledge available to people. There's also been a very big change in participation, whereas in the late 1970s, the focus was almost entirely on community health workers and very local community organizations. We've now had a spread of consumerism. People are acting both in terms of making decisions for themselves and consumer organizations, and the emergence of a wide variety of social organizations, including competitive political parties, specific disease-related organizations, and local government organizations. And this leads to a major challenge of leading a pluralist health system to provide some coherence in a complex context. There's a major challenge of management of health system change, and just want to reflect on a few thoughts on that although it's important to have a vision of where one wants to go with primary health care, it's also important to understand where we are. How is the current system operating? Where are people getting primary health care services? And where are the areas that improvement can be made? We need to recognize the agency of both users who are making their own decisions and providers of services who are responding to a wide variety of influences, including financial incentives. And we need to then think through new kinds of relationship with government. We need to build new kinds of partnership for disease management, particularly with chronic lifelong conditions. Clearly, health facilities and the public health system are important, but community groups are important, and individuals themselves are taking a lot of responsibility for caring for themselves and their families. How can this be articulated more in effective partnerships? And equally, we need to look at regulatory partnerships. Governments on their own find it very difficult to regulate sectors as complex as the pharmaceutical sector or the health sector. And we need to see what kind of partnerships of government, of civil society organizations, and of private organizations can lead to a more ordered health system. And in order to manage this well, government has a key role to play, and governments need to strengthen their reputation for competence and fairness and a capacity to lead what is change in a complex sector. Which leads me to conclude that the one thing that isn't articulated, I didn't put in that list about the Alma Ata Declaration. We saw that it is a statement by international organizations. It's an articulation of a technical approach to strengthening basic health services. It creates a vision of where we want to move, but it doesn't really articulate the politics of how health systems are transformed. In the early 21st century, we now have, with rapid globalization and economic growth, new patterns of inequality, social protection, and access to health care. New forms of inequality need to be tackled, particularly with the move of many, many people from urban to rural areas, and of the great importance also of migration and remittances. We have a much more complex interrelationship between local, national levels in terms of government, but also national companies who are involved, and global levels, both in terms of global targets, but also multinational corporations and global NGOs who are all involved in health sectors. Which means we need to look for new kinds of partnerships for primary health care, new ways of influencing the health system. We need to build political coalitions that recognize the importance of interests and power and how they influence outcomes. And we need to recognize that although it may not be government's role on its own to create a modern health system, but it has a key role to play in managing a change process and managing institution building. As we think about adapting a statement from the late 1970s to the realities of the 2010s and 2020s, we have to think much more clearly about the politics of the healthcare system and the politics of creating universal access to essential primary health care. I hope this lecture is contributing to the beginnings of that kind of debate.